Hello everyone, thanks for joining us today. My name is Ian Gassiep. I'm an infectious diseases physician and a clinical microbiologist based in Brisbane, and you're listening to the Pathology Report. Today I have with me Caitlin Keighley, and we will be discussing pathology stewardship. Caitlin, would you like to introduce yourself?
Hello, Caitlin Keighley, microbiologist and infectious diseases physician in Wollongong. Glad to be here.
Thanks for joining us. So, look, pathology stewardship is a kind of massive topic. Let's kind of start with kind of some of the simple things. What is it broadly, and why do we care? Why should we care?
Yeah, good. So pathology stewardship can broadly be described as doing the right test for the right patient at the right time. And why do we care? Well, there are a few reasons, but the key one should be patient outcomes. We want as better patient outcomes, as optimal as we can get to. That is sometimes confused or mixed up with cost. And I think it's helpful to separate the two, because really our primary outcome is to get the best outcome for the patient and avoid subsequent outcomes that are avoidable where possible.
Okay. Let's stick with cost for a second, because I like that train of thought. So can you give me kind of examples as to where you think cost might be the barrier, or where it is a barrier to kind of pathology stewardship or diagnostic stewardship? I'm thinking kind of higher level. You know, we as you say, it's doing the right test for the right person. I mean, I'll put it to you this way. It was really interesting listening to Juliet Elvey's talk about blood cultures and stewardship, and how she was discussing the number of blood cultures, right? And so it's quite interesting that you'd have someone say, well, it's stewardship. Does that mean we should be cutting down on tests? Where actually in blood cultures, it's to some extent the opposite, right? So instead of doing one blood culture, you're doing two. And so actually that theoretically is doubling the work, doubling the cost, but it's giving you a better outcome.
Yes, yeah, well, that's a good example. So let's just take that one. For blood cultures, it'd be a pretty easy thing to say, oh, we're spending this absolute number on blood cultures, let's reduce it. But actually, if you look at the blood culture and what it does for a patient, let's say I'm in hospital, I've got a temperature and I'm septic. If I have an appropriate number of blood cultures, 2 blood culture sets collected, and it's determined that I have Candida in the blood cultures, that completely alters the course of my hospital course and therapy, and probably means I get an antifungal that I would definitely not have otherwise got. And, baseline mortality for a Candida in bloodstream infections is 30 to 50%, and that's reduced to probably surviving the month. Yeah. Versus dying, to not to be dramatic. So we really need to be careful when we're estimating these things. Of yes, there is a cost associated with that blood culture, but it is dwarfed by the cost of what could happen otherwise if it isn't done.
Yeah, no. I mean, it's really interesting. That particular kind of talk and some of the papers that she was alluding to was fascinating, because my first thought was, when she was talking about changing the tack and saying, well, okay, instead of saying we're going to do just the 2 sets, if we say we're going to do just 1 site, what does that do? And it was really fascinating. I'd like to get your kind of take on what she was saying in terms of, the fact that the contamination rate didn't go down alone was kind of interesting to me.
Yeah, so she was talking about the traditional idea that you do multi-site sampling, and actually it probably is better from the data that we have available to do a single site but collect the 4 bottles from that single site. The contamination rates were similar, if not reduced, in some of the studies. And I think that makes sense, because effectively it's a little bit like having the diversion set. The first blood culture may or may not be contaminated. That would be the case regardless, but the subsequent 3 are possibly more reliable.
Yeah. No, it's fantastic. So I suppose then you've got stewardship in 2 different ways, right? You're saying, well, instead of taking 1 set, you're taking 2 sets. So you actually are increasing, to some extent, the amount of testing, broadly speaking. But
Right.
then you're decreasing the amount of work by only making it 1 site. So it's kind of a dual edge. So the reason I bring that up is because I quite like the fact that, or at least the narrative, that it's not just about narrowing everything we do, right? I mean, if we expand that, and the thing I was going to sort of lead into, and let's just say this segues nicely for the podcast's sake, is talking about antimicrobial stewardship and its role in, or at least the combination of diagnostic and antimicrobial stewardship. So to that end, I was going to ask, can you give us a little bit of a summary very briefly about our role as microbiologists in antimicrobial stewardship?
Absolutely. I think one of the things that is uncommonly focused on is it's not just about the test. It's about how the test is collected. So it's incredibly useful to have a urine culture to guide antibiotics so that they're not on the wrong thing and then exacerbating AMR. And certainly in our AMR crisis, a lot more of our therapy should be diagnostics driven. But the issue comes when the urine culture is poorly collected. And that comes down to a lot of education. And appropriate commenting on the report certainly help. And I think that's an area where actually there isn't a whole lot of research, and particularly implementation research on, what actually makes a difference for pathology labs to be engaged with, particularly primary care providers, but all referrers.
Okay, so that's awesome. I was going to press on, but before we press on with the actual antibiotics, let's take a step back and talk about the urines again, because that's a great example. So in that instance, the stewardship really there is probably twofold, right? It's what option A is, appropriate urine testing. So we're actually going to test people who've got symptoms, etc. But the other sort of component, which I think the New Zealanders do really well, and I do wish Australia would catch up, is it'll be a little more strict with being able to actually reject urines. What are your thoughts on their process of rejecting urines if there's no clinical details, or if the clinical details don't actually match what the microbiology laboratory might think is actually a clinically warranted test?
Yeah, I think it has a lot of validity, and there's a lot of research on its applicability in the hospital setting. And the reason it works potentially so well in the hospital setting is you've got a captive audience with your patient, and you can access the people looking after that patient really easily. So if something comes in that shouldn't be processed, and you get a report out saying we're not processing it, they can call and make sure it's processed. It is context dependent, and while those kinds of principles probably work quite well in a hospital setting, and particularly where the people ordering the urine culture tend to be more junior, just because of the nature of our teaching hospitals, a lot of those principles don't apply so easily outside of the hospital setting. So if you look at, for example, 58-year-old woman in remote New South Wales going and getting a urine culture that gets transported to a laboratory, if that does get cancelled, it potentially doesn't reach the referrer for a few days, by which time she might have actually ended up in hospital with sepsis, and it would be a really useful result to have. Yeah. So there are certainly aspects that can be applied, and I think there's a danger in the one-size-fits-all approach.
Yep, no, that seems fair. I suppose to some extent it comes back to it'd be awesome if the clinicians wrote down on the request form something that was useful for the laboratory. All right, no, fair enough. Okay, I mean, look, again, I'm tangential here in my thinking, because you made another really good point by talking about the rural patient. So, I mean, slightly, somewhat external to just obvious pathology stewardship, there's clearly an access issue there. Which I suppose, look, to be fair, is probably a little bit outside of the scope of this, but I'm just going to highlight that clearly access would come into the stewardship sort of sphere in terms of the fact that they might not have access to, as you say, the basic tests, or it might be such a massive time delay to said test. Okay, let's sidetrack back to what I was originally going to ask you, which goes to some work that obviously Marisa Graham has been doing for years, and it actually is doing world first stuff, talking about, implementing, selective reporting. So talk to me about selective reporting. What is it? Is it something we should be doing? Should the rest of the world follow Australia in this?
Yeah, selective reporting is not reporting every antibiotic that's tested, but reporting the ones that are most useful with second or third line options. And there is some data that suggests that people, what is reported influences what people prescribe. And one of the things that Australia, I think, has led the way on is not routinely reporting quinolones, and in conjunction with it being restricted in many instances, there's been a drop in usage and resistance across Australia. So that's a really good example.
Okay. Yeah, look, I mean, I tend to agree. I really like the kind of narrow spectrum reporting, because it almost, as you say, kind of gives the clinician a little bit of a nudge in the right direction. Instead of, here's some meropenem, I promise it'll work, you're going to go with something simple, right, like amoxicillin. It's great. But talk to me about the bigger impact. Is that really realistically going to have any kind of broader implications on antimicrobial resistance, or are we kind of kidding ourselves and thinking that a laboratory report has any kind of true impact? taking the nihilistic approach.
Yeah, look, I think it's an area that warrants further research, and along the implementation lines that we mentioned earlier, it's intuitive that what's on a report will have an impact, but it's also logical that the format and the comments and will differ in terms of how much impact they have, and we won't really know until we study it.
No, it's fair. I mean, I completely agree. I suppose you think about kind of, when a drug is released historically, and you look at the time from release to finding that first resistance mutation, it's well, it used to be years because we weren't really looking properly, and now realistically within months we're finding it, right? So
Yes.
so really, it probably, at least my feeling, it would have a massive impact, but it's going to be a massive impact over time, and maybe it would be kind of on a macro scale, maybe.
Yeah.
I don't know. Maybe that's, again, wishful thinking. I suppose the other thing is the direct antibiotic effect, right? So I suppose if people are getting, again, using that amoxicillin in urine example, hopefully less adverse reactions, hopefully less C. diff, etc. Let's talk a little bit about the sort of the front end, the clinician, before they are actually ordering the result. They're thinking they've got a patient who's got a urinary tract infection. They've got to go through an ordering process. We now have seen that there are a lot of electronic systems out there. Those systems, for better or worse potentially, have the ability to block certain requests. So that's kind of forefront of stopping that kind of chain of events of getting down to the incorrect test, incorrect result. Chat to me a bit about your thoughts on stopping prescribers from actually, or clinicians from actually ordering that test before it goes down that chain.
Yeah, or encouraging them to get
Or the opposite.
well-collected tests and the appropriate adjunctive things. So we heard a talk from Marisa Graham where they were putting an alert in the hospital system, which seemed to be working very well, and just informing clinicians that perhaps they'd already had that test done in a certain time frame, and had they checked the result, and here it was, and then looking at cancellation of tests, and a lot of the time it resulted in cancellation of tests, and look, those kinds of systems are phenomenally useful. I mean, I think back to mea culpa, when I was an intern and I was called to the hematology ward late in the evening to a febrile patient, and it was just easier to collect another set of blood cultures than check and realize I'd already had 3. Having an alert system early on, appropriately timed, could be really helpful in that kind of setting.
Yeah. I mean, it's the classic example of when they had their 17th blood culture for the day. Which number is the optimal number? But it goes into that classic example of the urines. I think her example was 3 days for the urines. There's a number of tests. I mean, if you expand it right into the rest of pathology, that classic that we all talk about, the CRP, right? So doing that daily CRP is probably not going to have that much of an impact. But yeah, no, I mean, I agree. I really think that the ability to have those what you would call soft stops in place to actually decrease that burden of work is amazing. The interesting thing I hadn't really thought about, and I'm really curious to hear what your take is that entire underlying theme of environmental impact, which again, I probably should have been more across, but I thought it was really interesting that the amount of waste generated and what the environmental impact is, and how we, from a pathology stewardship perspective, actually have some ability to kind of help.
Yes, yeah. Well, optimal use is critical, and waste will just be one of the things that is likely to benefit. Again, along the lines of the cost thing, that isn't a reason by itself to not do a test. It should always be about the patient outcome, because, I mean, yes, doing a test involves some waste, but not doing a test might, result in an ICU admission that involves a lot more waste as well as adverse health outcomes. So I suppose there are instances where not ordering a test is really useful. There are also instances where an alert, both in the hospital and the community setting, would be really helpful to encourage test ordering where it's not done enough. So one example of that is HIV serology. We've had really sad cases in New South Wales of young women who seem to be low pretest probability, presenting to healthcare multiple times, and eventually being diagnosed with, HIV they clearly had for a long time, that could have been picked up earlier. So those kinds of things, if they can be prompted to think of some of these really good screening tests early on, that could be enormously beneficial.
Yeah, that just makes me think about the syphilis kind of epidemic or wave that we've been living for the last few years. And it's the exact same thing, really, where it's the opposite of, and again, it's that stewardship being not narrowing but broadening, right? Increase or including the syphilis screening test in that person who, inverted commas, you thought had a low pretest probability. It's really interesting. Okay, so again, completely agree that having those electronic systems, for those facilities that have got it, having that barrier is great because, you reduce that inappropriate testing. I suppose the issue there is not really available to every public setting, every private setting, but also there's going to be a massive barrier in terms of GP prescribing. There's no, well, as far as I'm aware, no way I can see that we could have some sort of barrier for the GPs, or is there?
Well, I think actually GPs might be ahead of a lot of the public. So a lot of GPs use basically two common ordering systems. So if you think about the number of hospital systems that are used across the country, it probably is a bit easier in primary care, and there is some work going into having decision support. For a particular clinical scenario, having these are the right tests to order. These are the kinds of things that might be relevant in these other particular situations, like HIV, like a pregnancy test that might not otherwise be thought of.
Yeah, right. Okay, there you go. I was wrong. GPs are probably ahead of the rest of us. That's good to hear, actually. Okay, so then that then leads me into like the next question, which is along the same track, but it's not just stewardship, it's kind of implementation, right? If you have all of these systems telling you or prompting you what to do next, clearly there's an issue with, or potential issue for fatigue. Talk me through that. What do you think are the issues there? Are there ways to overcome it? Or is it something that we just essentially are just going to have to get used to as technology starts to kind of, invade everything we do in the clinical space?
Yeah, I think it's probably a matter of just getting used to it. There is a bit of alert fatigue literature, but I suppose it's a matter of having it so that it doesn't impede the workflow too much and doesn't take up too much time. I mean, we've all been through hospital ordering systems that involve, instead of typing, which is really quick, having to click through multiple different boxes and takes an extra couple of minutes no one has. Yes, I suppose it comes down to IT design.
Yeah, no, I mean, IT design as a whole is a nightmare, right? I mean, I just think about, as you say, that kind of clicking. How many times you see in the laboratory, they just click the first thing that's come up on the list, right?
Yes.
And the joke that they made, sort of semi-joke that was made about Ebola. I mean, I still remember when we first rolled out our system years ago, you could order equine virus, Venezuelan equine virus, all of these things where, it's like, you get this battery of tests that are nonsensical. And so I can clearly see that there's some issues with technology from that perspective. I mean, I am still a little bit concerned, to be honest, by the amount of prompts or alerts that you would get. And it's not just the sort of daytime ones. You're the resident at 2 a.m. and you want to order a blood pathology request form because, you got a febrile neutropenia patient, and then you have 17 alerts come up, and it just feel like, is that going to be realistically, is that beneficial, or is that so much time spent that you're actually now creating indirect or potentially direct harm?
Yeah, it's a really good point, and it just illustrates how important it is to get user input. And particularly in the busy hospital environment, it's really difficult to engage busy junior doctors. But if they're going to be the ones using it, it's essential in the design.
And I mean, that's the next thing, is that we're talking about such a broad variety of scenarios. You've got the hospital inpatient, hospital outpatient, private hospital, but then the general practitioners, which is a completely separate set. So I mean, the pathology stewardship there seems like it would be exceedingly different, because if you're a general practitioner doing an entire assessment, not just focused on the febrile neutropenia, then you might get alerts across the board. You haven't checked their blood pressure, hypertension, all of these other things that are happening. Oh, by the way, this test was ordered 3 days ago. Do you want to read through these 15 options to proceed with this test? The patient might never get care at that point.
Yeah. And I think you've illustrated the fact that we would like it for it to be simple and for it to be, there's just too many tests, let's reduce them in all contexts and all settings. But in reality, it depends on the test. It depends on the patient population. It depends on whether you're rural. It depends on whether you're in a hospital or in the GP setting. And there are going to be a number of different solutions that are best for each of those predicaments.
Thank you. So, I mean, look, I'm just going to kind of slowly wrap this up, but it seems like we've covered a fair amount of ground here, talking about a wide range of issues. I mean, a large percentage of this is to some extent dependent on the scenario and the situation, which is fair. And realistically, the other major takeaway is that, you know, the pathology stewardship it goes in both directions. It's not limiting pathology, it's the appropriate test. So you might actually go from ordering 1 to 2 to 3 tests, which is in and of itself stewardship, because you're ordering the correct tests for the correct patient at the right time. And that's my summation. Is there anything you'd add to that? Does that kind of nutshell it?
I think it does, and I think the other thing to say is that you know, across Australia we have excellent health outcomes. We are the envy of many countries in the world, and we have governance and regulatory structures that mean that we spend a lot less on pathology and medicines than other countries per capita. It's astonishingly small how much we spend per person. I think it's in the order of 3 or 4 cents per person per year. And so with any of these tweaks that we want to put in place, I think we've got to remember that sometimes what another country is doing is not better.
Great. That's a great message to end on. Thanks very much, Caitlin.
It's a pleasure. Thank you.